All right, everybody. Sorry about that. Like I said, we'll get back started here with stroke. Like I said, my computer's got some kind of issue going on where it just kind of freezes up. So we'll make sure that we have the videos uploaded. It'll probably just be 3 videos instead of just 1. So just be looking for that as a 3-part video. Hopefully we can get through the rest of these. So I was telling you guys about stroke. I hope that you got some of that. It's again, those blockages happen in those vessels in the brain, and causes the brain to dysfunction, whatever hemisphere is affected. But a lot of times they're still going to have some of the same ones. Again, those transient ischemic attacks, the TIAs and mini strokes, those are usually some of the smaller vessels that maybe don't affect it as much, but those are usually preceptors to having a stroke. That numbness or paralysis on one side, again, can look like can be kind of severe, or you have real, just no use of the arm, no use of that other leg. The facial drooping is real bad, eye drooping, all sorts of stuff. So, some of these, again, are inability to speak, just real slurred speech or difficulty speaking, difficulty seeing, unequal pupil size, unconsciousness, seizures, respiratory arrest, incontinence, which is essentially using the bathroom on yourself, or just not having control over how you do that. So whether it's urination or defecation. So, and then unresponsiveness. Again, all of these aren't inclusive in a stroke type patient. I mean, it could have 2 or 3 of these. It could have several of these. So it just depends. So that's why we do a good exam of our patients and really try to see what we can get from that. They have a little scale they call the Cincinnati Pre-Hospital Stroke Scale. I think there's usually 2 that is used pretty commonly. This is just one of them, and just to determine whether or not a patient may have experienced a stroke. So it doesn't have any special equipment. It has this little table here, kind of goes over it a little bit. And, that was one of the things I wanted to point out with this, and any of these that we come across. If you, I know veteran paramedics and nurses and doctors and flight paramedics and everything else that have, little cheat sheets, little guidebooks, reference guides, all sorts of stuff to make sure that they're not missing something, to jog their memory, all that sort of stuff. I have one that I keep in my bag, and I mean, when I'm with the patient for a long time, I'll kind of go back through it, and I'll make sure that I'm not missing stuff. And it's everybody, you just can't retain all this information at such a high level forever. So, I mean, you're going to lose stuff. You're not going to do some things. You're going to come across patients that you just have never had to deal with before. And you just need to jog your memory. You need to have a little bit of, a kickstart for that treatment plan. So it is absolutely in no way a ding on you. It doesn't make you look bad. Obviously if you constantly are just having to go back to that all the time and you really don't understand, at all, then there's an issue there, right? But if you just need it to kind of, like I said, get you jump started, absolutely no problem with that. And so any of these types of scales and, all these different numbers and stuff like that, writing them down and kind of glancing at them, absolutely, understandable for you to do that. So as you can see there, it kind of breaks it down into facial droop, arm drift, and abnormal speech. Can y'all hear me?
Yes, and now I can actually hear. I'm back.
All right, good deal. So one of the big things is you guys is Rob and I are actually using the same internet tonight, and so we're kind of dragging on this internet. So I apologize, but so with this scale, it's actually a series of tests. So we have a potential. Our general impression of the patient is that they potentially have had a stroke. They're showing some signs and symptoms. We just get them to smile. Hey, just smile for me real big. I know you feel uncomfortable and you feel weird. I know it sounds silly, but I just want you to make a nice big smile for me. Okay, try as hard as you can to smile real big. And if they have that facial droop, on one side, one side moves, the other side doesn't, that sort of thing, then, that'll tell you something right there. Both sides of the face move equally. That's pretty normal. Arm drift, we have them put their arms out in front of them, straight out in front of them for 10 seconds and see if one of them starts to drift down or away or something like that, and that's abnormal. Okay. Abnormal speech, same thing. You can't teach an old dog new tricks. It's just a quick little phrase to kind of a little sentence to say. Again, if they slur words, use the wrong words, or are unable to speak, that's generally an abnormal reaction. So again, you do those three things, we can kind of we can reasonably assume that they have a neuro deficit. Okay. So you can tell them, on your pass down, hey, I conducted the Cincinnati test, and it was it had negative results, and I'm pretty sure they have some type of neuro deficit. The other one that I use a lot is having them squeeze my fingers. So I have them squeeze my hands or shake both my hands, and do it at the same time. And one will generally be weaker than the other. So that's just another way to do it. First priority again is just at our level is to make sure that we get as much information as we can, but we're going to make sure that their ABCs are intact. Administer oxygen using a normal breather mask. We don't give them a ton of oxygen. We just want to keep their saturation level, their oxygen saturation level at a normal state. We don't want to because a lot of times if you can over oxygenate a stroke patient, and it's bad for them. So if the patient's having a seizure, try to prevent further injury, like we talked about, and then again, if they for some reason need rescue breathing, we're going to do that for them as well. Same thing if they're conscious and they're just like I said, they're having this facial drooping and they're weak and also their stuff, they're kind of maybe out of it, then we would we definitely want to again provide some of that emotional support, talk to them, just try to keep them relaxed, have ALS come in and make sure we're going to have the ambulance come and pick them up, and hopefully, and we want to do that soon, especially in stroke patients. The sooner the better. Time really is a big deal with stroke patients, because the sooner that they can get to a stroke center, then they have a protocol set up specifically for that, and they can help to bust those clots up in their brain with some drugs and dissolve those clots. And so there's a few places actually around here that are stroke centers, and so it just you don't necessarily need a surgeon and all sort of crazy stuff. It's just a round of the appropriate medications in the appropriate amount of time to do something about it. So diabetes, again, a pretty common one that we deal with in EMS, and it is usually hyperglycemia or hypoglycemia, and essentially there's not enough sugar in the blood or there's too much sugar in the blood. Okay, so just to kind of put it simply, but the body produces insulin, which enables glucose or sugars to move into individual cells. And so that's essentially fuel, right? So we need that fuel for the cell to be able to produce. So if the body does not produce enough insulin, the cells become starved for glucose and diabetes results. Okay. So hypoglycemia, hypo meaning low, hyper meaning high, occurs if the body has enough insulin, but not enough glucose. Okay. So hypoglycemia may be where, especially if you are insulin dependent and you take your medicine, but you don't eat, then you got the insulin part, but you're not getting all the sugars and complex carbohydrates and all that stuff to break down and all that in your meal to provide that glucose. Okay. And so that's usually the issue. Signs and symptoms, again, pale, moist, cool skin. Usually that rapid, weak pulse is pretty common. Dizziness or headache at a more severe hypoglycemia, you're going to have that dizziness, confusion, almost unconscious state potentially. We've had several accidents from people passing out because their blood sugar was too low. I'm sure some of you probably may have seen this before, have a family member that's been affected by it, and it's it's scary. It like I said, it comes on pretty quickly, and they wake up. They wake up and they get in a hurry and they get out the door and they forget to eat and they forget to take their medicine or something like that, or a combination, and usually it'll start hitting them. Excuse me. So sweating is another one. Like I said, just won't necessarily be all of these signs and symptoms, but it could be several of them. But again, generally when you have a patient that's pretty bad off, you're going to definitely have the confusion part. So that altered mental status. Hunger is another one. A lot of times they're going to be really thirsty. Rapid onset of symptoms, like I said, just within a few minutes. So a lot of times it doesn't take very long. Like I mentioned earlier, they may appear drunk. So again, like I said, at that later stage, they're going to be out of it, stumbling, somewhat lethargic, just, really have very, very close signs and symptoms to somebody who's drunk. So there's been plenty of people that have been pulled over who've been in, diabetic emergencies and having hypoglycemia or hyperglycemia, and almost confused police, and have confused police before that they were drunk. So they really had to do intoxilizer or portable breath test and things of that nature to rule that out. But nonetheless, we want to make sure that we have some type of judgment there. Obviously, we want to ask some qualifying questions, right? And a good DUI officer will do that. They're going to ask, hey, do you have any medical conditions? Are you taking any medicine? That could cause you to be acting like this, that sort of stuff. And if you're a diabetic, generally you're probably going to say something about it. So it's going to come out in the wash one way or the other, but usually we try to cut that off head that off at the pass before we end up having to take them to jail or something like that. So if the patient's able to swallow, have him or her eat or drink something, they really need to be at a decent level of consciousness for you to be able to do this. There have been plenty of times, 3 o'clock in the morning, be at somebody's house, and they're just forgot to eat dinner or something like that. And we have made them a peanut butter and jelly sandwich and sat there and watched them eat a peanut butter and jelly sandwich until they come back to normal. I mean, it's night and day. Or they may, have like a really sugary drink, like a Coke, or, like a full-on Coke, not a Diet Coke or anything. I mean, a full-on sugary drink, and let them do that. Again, these things, those little shortcuts like that are just that. They are shortcuts. They are not the means to the end. That is not the definitive treatment, okay? They have got to have a meal. They've got to have a meal, or they have to have a considerable amount of dextrose, by IV in order to kind of keep them maintained on a pump or something like that. So they are going to have some complex carbohydrates, some, sugars, some, fats, things like that to break down and all that. So it's important that they do that. Like I said, a lot of times when you do that, they come back to life and they go, oh yeah, I don't want to go to the hospital. I'm good. Okay. it's always our advice to make sure you go eat a meal right now. Go eat a full meal of something soon, and make sure you take your medicine. And because again, we at that point we can't make them go because they're they're alert and oriented. They're legally we can't just make them do anything. So we have to tiptoe around that and make sure that we're giving them some good advice, and hopefully they follow that. And if they don't, then more than likely we're going to be right back over there. Okay, and then we're going to end up probably taking them to the hospital. And it's usually what happens. But again, the paramedic may also administer D50. So that D50 dextrose is going to be by IV generally, and they'll usually come right out of it. A lot of times you'll see that when we have a strong suspicion that they are hypoglycemic and they are unconscious, and that way the paramedic will usually start an IV in that unconscious patient and try that D50. So, but again, like I said, same thing, almost like with Narcan, they will come back to life, sometimes swinging and confused and everything, scared and all sorts of stuff. So you got to be ready for that to, just snap right out of it almost at some point. They'll start moving around and fluttering, open their eyes a little bit. And then all of a sudden they're like, whoa, where am I at? Who are you? Why am I here? So when you have that, you just have to be cautious about it. Another thing is that you may see, again, it's just one of those things where it's out there, but it's not something that we're going to necessarily use as first responders, but it's oral glucose, and they have several different types out there on the market, glucagon and glucose 15. These are just all sorts of different versions of it, but generally it's just a hyper condensed concentrated substitute and oral glucose gel. And man, you'll just if they're conscious enough to swallow and all that stuff, and they have a good enough level of consciousness, we can assist them with that, and they can kind of squirt it in their mouth and eat it. Again, most of them, I know this one says lemon flavor and grape flavor, but generally they do not taste good at all. And so a lot of patients don't like it, but it's one of those things where it'll bring your glucose level up pretty good, pretty quick. And but again, it still has to go through the bloodstream. So, but like I said, if their level of consciousness is too low, we are not giving them anything by mouth. Okay. So diabetic coma is occurs when the body has too much blood glucose and not enough insulin. And so again, we have plenty of glucose, but no insulin to exchange it. Okay. Some of those signs and symptoms might be, are definitely more likely going to have a history of diabetes. Warm, dry skin. Okay. So that's kind of a big difference, having that warm, dry skin, rapid pulse, deep, rapid breathing. The other kicker on the late stage is fruity odor on the patient's breath. Okay. Again, they have so much sugar that the body's having to get rid of it, and it's actually manifesting itself through the blood, and the blood in the lungs that goes to the lungs has that fruity, sugary, type, smell to it. And so generally you're going to have some type of fruity odor on the patient's breath. So like I said, weakness, nausea, and vomiting, increased hunger, thirst. Like I mentioned, thirst earlier. That's usually a pretty common one with that. The slow onset of symptoms may take over a few days for it to happen. And like I said, it says here, misdiagnosis is common, and that's one of those where generally you're going to start to see them they're feeling bad for several days, but they're not having that complete lack of loss of consciousness or altered mental status, and it may take several days instead of being a little bit more rapid like what the other one would be. Some of this would be, as you can see here on this table, some of the differences here. Like I said, pale, moist, cool skin would be for hypoglycemia. And then, like I said, that one of those big differences is warm, dry skin. Okay, we still have a rapid pulse with both of them. You could have some rapid breathing for hypoglycemia or labor, kind of slow breathing, but rapid breathing for diabetic coma. Obviously, in a diabetic coma, you're not necessarily going to have that headache part, just because you're probably not going to be able to tell anybody about it. And then that acute confusion and unresponsiveness, one may just take longer to happen. Okay. The rapid, as you see there, rapid onset, and then the slow onset for those signs and symptoms is another one of those big ones. So as we're getting our history, hey, what's been going on the last few days, whatever, and they say, oh yeah, I've been progressively feeling bad and this and that. Okay, that's probably one of those things where it may have resulted in a diabetic coma. Excuse me. All right, so talking about abdominal pain, like I said, is a very generalized term, right? So we have tons of different reasons for abdominal pain, and we're going to talk about a few of those. So obviously the contents of the abdomen are divided in hollow and solid structures. So a lot of it are kind of hollow, right? We have our intestines, which are just big tubes. We have our stomach, which is just like almost like a vessel, and we have some of the things like kidneys and liver and stuff like that are a little bit more solid. So those solid structures produce substances. I mean, they usually produce bile. They produce some type of they produce something that we need for digestion or filtration or something like that, right? So acute abdomen, just the generalized acute abdomen. So something, all of a sudden you have abdominal pain in general. A lot of times just irritation of the abdominal wall itself. It's not really anything inside per se. I mean, it's not necessarily an organ or anything that's an issue. It's just the abdominal wall is irritated. Could be an infection, could be blood in the abdominal cavity for some reason. Sometimes we have what's called referred pain, so pain that is kind of manifests itself in another part of the body or near there, so it kind of radiates around. The abdomen may feel hard, okay? So as you're pressing on it, you're doing your focused physical exam, and you're pressing on the belly, and it's really rigid, okay? And then nausea, vomiting, fever, diarrhea, those are, again, potential signs and symptoms as well. So it says some patients will vomit blood, and so it could be because they're bleeding from the esophagus or the stomach. Like I said, one of those things where it's gravity, right? So things are just going to kind of go down, and generally when that happens, they're going to get too much blood in their stomach, and it's just going to cause it to upset, and they'll vomit it. Generally, they'll probably know that. They'll probably taste it. They'll taste it in their mouth before that happens. If a patient has abdominal pain, again, monitor vital signs. So especially for abdominal bleeding and things, we're looking for usually a fast heart rate. Any type of internal bleeding, we're looking for a fast heart rate, lower blood pressure, rapid breathing, things like that. So treat symptoms of shock. Again, just like I was just telling you, those things are kind of symptoms of shock. So we're looking for that, and we want to try to elevate the feet, elevate the feet and legs, and maybe even the head a little bit, trying to get some of that blood to come back down to the core. Keep them warm, and again, warm and comfortable. Another big one. This is the bad boy right here. The abdominal aortic aneurysm, or the AAA. This is a killer. Okay. This is one where, excuse me, this is one where one or more layers of vessel, specifically the aorta, which is the main vessel coming descending down into the body, that's going to branch and create your major arteries in your legs and in your lower body, starts there. Okay. And so as that descends and goes down, some of those layers just are weakened. They have some deposits that build up on them, make them weak and deteriorate. And so this starts to shed some of those layers, and blood starts to flow behind it, starts to peel away those layers, starts to, make it weak. And that is, it could be, like it says here, from high blood pressure, diabetes, atherosclerosis, which is that hardening of the arteries or build up there, and heavy smoking. But so when this happens, generally you're going to have like a pulse, almost like a pulsating mass there around the center of the stomach. And if that, this is a serious medical emergency. Okay. If you don't do something about a AAA pretty quickly, bringing that blood pressure down, things like that, give them the right medicine and all that. If it ruptures, your patient's going to die within a couple minutes. Okay. There's no, if they're in the field, even on the operating table, they could die with a AAA within just a matter of a couple minutes. Okay. It is one of the major, your major lifelines in your body. Okay. It supplies all the blood to your lower body. Okay. Big deal. So again, treat for shock. Again, try not to move them very much. Definitely don't roll them over on their stomach or anything like that. Handle them, like it says, handle them gently. Make sure you get somebody and you get an ALS unit there immediately, and let them know that what you found. And like I said, more than likely, if you have that pulsating mass and that weak, thready heart rate and all that, you're probably gonna be dealing with a AAA. Kidney dialysis patients, like I said, was another one that we kind of deal with a good bit. You see them getting transported all the time in some of these vans and the transport vans and all that take them from their house to dialysis. Typically a chronic issue, so something that happens over time, and most people are pretty well versed in what their situation is and what they have to do and all that. But essentially the kidneys aren't able to filter out those waste products that come through there, and it from their bloodstream, right? So they end up having some type of renal failure or kidney failure, and in order to prevent that, they have to kind of go there and get that filtered out through dialysis. So hemodialysis again is whenever they do that, generally they'll put in the shunt in their arm or generally their leg, and that will that's just a port. That port is essentially just a quick connect for the people at the dialysis center to filter that blood. Again, be careful with the shunt. Don't take blood pressures over that shunt arm. Use the opposite arm or leg if you're checking vitals or anything like that. And just like I said, just be really careful with that thing. You don't want to occlude it or block it off or damage it or anything like that. So patients may experience emergency related to their dialysis treatment. Again, sometimes whenever they go for dialysis and they're fine, and usually they're really tired afterwards, and then they come back home, and sometimes they may have low blood pressure due to some of that blood, the changes of blood levels in their body, and shock due to decreased blood pressure, and they're hypovolemic shock or something that along those lines where the body feels like it doesn't have enough blood. Internal bleeding could be issues with again, like we just talked about earlier with the AAA or some of those things where you have vessels that have been affected and are weakened and stuff like that, and so they may have, some of that blood moving through there and being changed out may have affected some of that, maybe broke something loose, and they started having some type of internal bleeding. Abnormal levels of electrolytes, which can cause cardiac arrhythmias. Just abnormal levels of any type in the body usually kind of throws it for a loop, and you have some type of side effect from that. So again, you may be dealing with these types of issues with patients that are coming back from dialysis. All right, so like I said, we covered several things, and this is like I mentioned earlier, is kind of a preceptor for the some of the other chapters that we're going to go more in detail on these things. But these are some of the medical issues, not trauma, but the medical issues that we're going to see, pretty often. All right, these are some of the big ones. It's not all inclusive. This is not all of them, and we're not necessarily going to touch on all of them. But these are the ones as a first responder that you can, recognize, identify, and actually try to do something about. Can everybody hear me?
I hear you.
Okay, good deal. All right, so like I said, we'll get more in depth in some of these as we go along, and we get into cardiac and a few other things, behavioral and all this other stuff. But again, these are some of the big ones that we experience. Okay, it's like I said, important for you to read your chapters. Okay, dig through there. There's probably a little bit more information on each one of these in your chapter. So make sure, like I mentioned earlier, that you're kind of digging a little bit deeper and you're reading into it, and try to understand those a little bit better. If you have questions, I know, like I said, a lot of these signs and symptoms, especially on the breathing side, stuff like that, are pretty close. Okay. So if you're having concerns about that, you're not really sure what the differences are, please reach out and let me help you. Make sure you're taking your quizzes. Again, those of you who are 2 or 3 or 4 quizzes behind, okay, it's not good. You need to get in there and knock those out. If we're not doing that, I'm going to start reaching out to you individually, okay? And we're going to have to figure something out. But you really don't need to get, as we're starting to progress into a lot of the medical stuff. There's a lot more to read. There's a lot more to understand, okay? So let's go ahead and knock those easier chapters out and be done with it. And that way we can focus on some of this more important stuff, okay? So your class code for tonight is going to be R0007. R0007. Again, like I said, if you have any questions, again, feel free to reach out, and I'll try to help you as best I can. Read those chapters, take those quizzes, and we'll see you guys next Tuesday. Have a good night.
You too.